Yes, thank you very much for the introduction. Probably from my background, you'll notice that this is a slight departure from the main body of work that I do, which is mainly in environmental health. But this project is related to a larger project that I am a part of, co-investigator on. When the pandemic hit, the larger project we knew was going to be impacted, and so we pivoted to actually assess what kind of an impact this was going to have on our project and what we could sort of generate in terms of findings and in terms of helping inform public health practice and also policies. I would just like to quickly acknowledge that I am based currently in Edmonton, actually at the University of Alberta, which is located on Treaty 6 territory. So thank you. Before I get started, I would actually just like to extend a really big thanks and a shout out to the team who has been working with me on this project. So we're kind of spread across different areas. So we have a couple of researchers from the University of Calgary, Keith Dobson and Jessica Lee. Shihiro's Premji is actually from York University. Our Chinese counterparts at Anhui Medical University include Fang Bao Tao, Bebe Zhu, Yan Hu, and Gu Yue. And the rest of us, including myself, Gian Jangri, Chunhui Tian, and Holly Silverman and Tianxi Zhao are actually based at the University of Alberta. So thank you. So I just quickly want to start out with a short background to sort of orient the project and the work that I'm going to be talking about today and some of the results that I'm going to be talking about today. So the work is really focused on the mental health and sort of the psychosocial aspects of the COVID-19 pandemic. And we specifically focus this work on two populations, the healthcare provider population and pregnant as well as postpartum women. And we also extended this work to actually look at what kind of impacts this might be having in terms of birth outcomes in these women as well. So just to tell you a little bit about where the study is being done. So the study is being conducted in the Anhui province of China. But China in general, just to give you some more details about mental health in China, the direct annual economic cost of mental illness in China is approximately 89 billion. As of 2013. So even this data is a little bit outdated. And so this, I wouldn't be surprised to find out that this information is this cost is a little bit low, especially given the pandemic. Antenatal and postnatal depression prevalence has actually been estimated in a few different studies and ranges anywhere from between 6 to 28%. But unfortunately, the mental health service capacity has not necessarily kept pace with this. So what we have observed, according to the data that we have, is that only about 1 bed per 100,000 persons are available for mental health services, as compared to the international statistic of 4.4 beds per 100,000 persons. So we're talking a little bit lower in this part of the world. So as I said before, the study is actually conducted in the Anhui province of China. And so you can see sort of from the map, a small map in the corner, that it's sort of in the southeast part of China. And the cities in which we are focusing the work for the larger projects are in Manshan and Hefei, you can see here, and Bengbu, and also Jishu, which is not on the map here. But so those are the 4 main cities that we're focusing the work on and we're scaling the work up to. But just to give you a little bit of context about the COVID situation in the Anhui province. So the first confirmed case was detected on January 22nd of 2020. This was unfortunately quickly followed by many more cases, 779 in the next 2.5 weeks or so, also in the same province. But because of the very strict lockdown measures and the restriction on travel, the number of cases has actually not substantially increased in this region. And so as of checking on the statistics yesterday, there were only 1,008 total reported cases of COVID-19 in the region and 6 COVID-related deaths. So I just quickly want to provide a little bit of context for the COVID project, which I'm going to be going into in the later part of the presentation. So the larger project in which the COVID project is embedded is actually focused on screening and management of perinatal depression in primary care. And it's part of the suite of projects that are funded through the Global Alliance for Chronic Diseases. So the parent project, or the larger project, is really focused on developing and implementing the screening and management of perinatal depression care within this primary care setting. So the first two objectives, for example, are focused on assessing depression in this group of individuals in this group. So the perinatal depression and screening management program, or the PDSM, is where during the first for the first aim. This is where we develop this. The second aim is really focused on assessing the intervention, which I'm going to be talking about a little bit later on, which is an internet-based cognitive behavior therapy intervention aimed at pregnant and postpartum women. The third aim is really about the implementation aspect. So it has to do with scaling this up to the other sites. So our pilot study was conducted in Manshan and scaled up to the other 3 sites that I had mentioned. And so, yeah, we're in the process of assessing things like reach, efficacy, adoption, and implementation around the program in this area. The protocol that we have adopted for the project includes a baseline screening. So women are recruited through their primary care providers when they come in for prenatal care. And so in addition to prenatal care that they receive in the checkup, then we also do a baseline screening for depression in these women. And so we use the EPDS, or the Edinburgh Postnatal Depression Scale tool, to assess depression. And so we have different protocols or different sort of treatment schemes for women, depending on where they fall in terms of the baseline screening. So those who have a score, EPDS scores of less than 9, they're deemed at low or no risk or lower risk. And so then we just follow them up in the subsequent screenings after the baseline screening. For those that are in the low to more moderate levels of EPDS, of the EPDS scale, from 9 to 11, we do offer them the intervention, which is termed Mom's Good Mood. And then we do some follow-up screening as well. For those in the moderate to higher category of 12 to 13, we do offer them also the intervention that has been the internet-based cognitive behavior therapy intervention that we have developed, plus counseling, and we also follow up in the subsequent screenings with them as well. And lastly, for those women who are scoring in the 14 or higher range, then we do offer them again the Mom's Good Mood, the counseling, and we do send them for psychiatric referral, as we do women who express any sort of suicidal ideation. So the intervention itself is actually based off of a WHO Thinking Healthy program, and we took the sort of the basics behind this Thinking Healthy program and tailored it to this specific population and to this particular setting. So we've termed the intervention, the internet-based cognitive behavior therapy intervention, as Mom's Good Mood. It is offered through WeChat, which is one of the most used popular communication tools in China currently. And it is internet-based so that it can foster access and availability for the women. So you can see here from these two screenshots that the program is largely sort of self-driven. There are a number of videos, there are some articles, there are some little quizzes that women can take, and they get as they work their way through a series of the little 11 modules that are part of the intervention. So yeah, so the women can actually start and stop as they have time, and they can just sort of start again when they have a few more minutes. So it is designed to be quite flexible in terms of how and when people can do it. So in terms of where the COVID project fits in with this, so we started the bigger project in 2018, and when the pandemic hit, we knew that this was going to have an impact in terms of the work that we were doing. And so we developed another project that actually was going to study the impacts of the COVID-19 pandemic, not only in terms of our population, but in sort of taking those results and determining how they could be translated for this particular population. So the objectives are really building on sort of the existing work that we have in a bigger project. So the first objective was really to, again, to revisit perinatal depression to see what was happening in this population during the COVID-19 pandemic, and to assess experiences of women during this period of time. So we used and are using both a mixed methods sort of approach, including qualitative and quantitative data collection. And the second objective is actually, again, to assess the impact of the Mom's Good Mood, or this internet-based cognitive behavior therapy program in these women at this time. The third objective is sort of extending the original work that we're doing to assess, again, the birth outcomes that I was talking about. And we're lucky that we're able to take advantage of the longitudinal data that we have, because the cohort was set up prior to the pandemic. And so the thing is, we're looking at following up these women across these different time frames. So pre-pandemic, during the pandemic, and hopefully we'll be able to collect another round of data collection in the near future as well. The fourth objective is represent a newer area that wasn't an original focus, pardon me, of the study. It is actually looking at healthcare provider anxiety in healthcare professionals. And so again, we've adopted a qualitative and quantitative data collection approach to capture, using the mixed method approach to capture data in this population. Okay, so now I'm just going to briefly be talking about a few of the preliminary results that we have that are emerging from this study and where we still have yet to go. So regarding the first objective, like I said, we do have data that was collected prior to the pandemic. And so we do have a bit of that longitudinal trajectory, which is quite nice. So we started collecting in 2018, and the data for this will end data collection for this will end at the end of this year in 2021. The main outcome that we are looking at with respect to this population is perinatal depression. And so it's part of, again, built into the screening program that we have already set up in the study. So for the COVID project, we actually, when we went back and reevaluated, or we're assessing depression and experiences of women, we focused back on the pilot study because the thing is, the data collection had already been completed in that stage. The other 3 sites, we were in the process of scale up. And so we just thought it would be easier just to focus on the one city at this stage for the study. And we conducted a series of interviews again with the women between May and December 2020 that were conducted in Mandarin using WeChat and via WeChat. The one thing I do want to note with this is that even though we were well placed having the sort of the pre-pandemic data, it did take us a while to pivot in terms of data collection, in terms of getting approval and the funding in place. So by the time we started data collection, because of the nature of the waves in China, which hit a little bit earlier than it did over here in North America, we were actually collecting data sort of on the tail end of when we can see the cases starting to decline again, and the rates starting to decline, and some of the public health measures starting to be lifted. As for the perinatal depression results that we're starting to get, again, this is a pre-COVID data. I'm sorry, I don't actually have the COVID data to actually share with you at this stage, and again, so this is for Manshan. And as you can see, we have scores that for the prenatal, broken down by prenatal and postnatal. And most women were scoring within the 0 to 8 range. So again, that very low risk of depression according to this scale. We had a few individuals, women who were in the 9 to 11 range. And again, some individuals that were also in the 12 to 13 and 14 plus range, unfortunately. And so anybody who scored above a 9 or above on EPS scale was actually offered the Mom's Good Mood intervention plus any of the other any of the other treatments as deemed according to the protocol that we developed. So we conducted 15 interviews with women from this group between May and July of 2020. Most of them had actually had downloaded the app, so the Mom's Good Mood. And so we were able to ask them a little bit more about, how you used it, what did you think of it, to get a little bit more information about the impact that the app is having in this, during this period of time. So some of the themes starting to emerge from this data indicate that, again, we can look at the concerns or the information or the themes that are emerging first in terms of more general sort of concerns or more general information that is that women spoke about, which includes social and family supports, concerns about work and financial situations, and just general concerns about pregnancy and childbirth. On the pandemic side of things, we had a lot more specific themes that were related to things like access to healthcare services and availability of perinatal healthcare services. Again, this theme of social supports and family supports was something that also emerged during this period of time, or in these conversations with the women. Concerns about pregnancy and the physical health of both the mother and also the fetus and the infant as well. And again, the theme of work and financial concerns also arose in our conversations as well. And lastly, this idea of protection and prevention and how to prevent themselves, their family members, their newborns from contracting COVID-19. Also, we were able to ask them in the conversations more general questions about their views towards mental health, because there is quite a stigma still attached to mental health issues in China. So we wanted to get a sense of where this was and what it looked like. We also asked, and we got feedback on the Mom's Good Mood program, because a lot of the women had downloaded and used the app, which is good. And another related piece of information is we wanted to know where they were getting their information and their news from regarding pandemic protocols and public health protocols. For the second objective, which is to assess the impact of Mom's Good Mood, I don't have any pandemic data to share with you, but I can share with you some of the pre-COVID preliminary findings. So we did do some quick analyses to make sure that that the app wasn't doing any harm. And so our analyses actually indicated that app use was associated with a change in EPDS scores between the baseline assessment and the second assessment when we followed them up some weeks later. As you can see, the results indicated that the app was actually reducing was associated with a reduction in EPDS scores. So hence, this is why we continued on with the study. For the third objective, this is one in which, again, we're still analyzing the data, but we have the data collected. So we have the data for the women that have been recruited into the study about the adverse birth outcomes. And so that is in the process of being translated and being cleaned and analyzed. But we also did conduct a scoping review associated with this objective, because we wanted to know what other folks in other parts of the world had been doing in this area, and if there was anything that we could build on. And it turns out that, and maybe we just did the scoping review a little bit early, but there hasn't been a whole lot that has been done in terms of looking at adverse birth outcomes in relation to mental health or psychosocial health issues in pregnant and postpartum women. And we didn't restrict it by any sort of geographical area. So it's not like we were just looking at China. We didn't really find any sort of studies that were yet focused on this. So they might be still emerging. So this definitely represents a gap in the literature. So the last objective is really where we've done most of our work so far to date. And this has to do with assessing healthcare provider anxiety and healthcare and health service provision. So the original plan with the study before we started is that we wanted to assess the same group of healthcare providers over different time periods. But given the logistics of following these individuals up and tracking them down and sort of running in the background, of course, is the pandemic and people being reassigned, we just found that it was going to be too difficult to follow the same individuals over that period of time. So we had to pivot a little bit to change our methods to include, to be a repeated cross-sectional study. And so the thing is, like, we have 2 time points in which we've collected the data from different individuals. We do have some overlap. We do have about 100 individuals that filled out the survey in the first wave, and then in the second wave as well. But the 100 individuals is not really a whole lot of wiggle room to do some of the analysis that we were hoping to do. So, but we will still look at that group of individuals, but again, we have to treat them as separate groups. So as I had mentioned, the waves of data collection, there were 2 waves of data collection. The first was in June of 2020. And we just repeated this again in April of this year, in 2021. And the primary exposure that we looked at is actually working directly with patients during the COVID-19 pandemic in the Anhui province. This didn't necessarily mean that the healthcare providers had to be on the front lines working directly with COVID patients. We just wanted to know if working with patients in general was actually associated with higher levels of anxiety. So the primary outcome was anxiety among healthcare professionals, and we assessed this using 2 different tools, which I'm going to discuss in the next slide. Again, all of this was offered through WeChat platform because it was just the easiest to disseminate and to share with everyone. And we also interviewed a series of healthcare providers as well between May and December of 2020. And again, these were conducted in Mandarin using the WeChat app. In terms of the survey itself, the online survey had 3 different components. There was the demographic survey, which just basically collected all kinds of demographic information. And the 2 anxiety measures that we included in the survey were the state trait anxiety inventory for adults and the generalized anxiety disorder 7-item scale. So the state trait anxiety, the full state trait anxiety inventory survey or tool is a 40-item tool, but we were just specifically focused on the state anxiety because we wanted to capture what was specifically happening during the COVID-19 pandemic. So this cut the tool down to 20 items that are assessed on a 4-point Likert scale, and participants actually assessed statements such as "I feel tense," "I am worried," "I feel calm," "I feel secure," with answers that are almost never to ranging from almost never to almost always. The GAD-7, or the Generalized Anxiety Disorder 7-item scale, is actually very, very short. And again, it's meant to assess generalized anxiety. And one of the reasons we did this is so that we could map the findings from this onto the a probable diagnosis for generalized anxiety disorder using the Diagnostic and Statistical Manual of Mental Disorders. So we used a cut point of greater than or equal to 10 on this particular tool, which has been widely used in the literature and has been assessed as a cut point. So here are some results looking at comparing sort of the different waves. And again, just keep in mind that these are different groups. So in terms of the proportion of individuals that had direct patient contact in 2020 versus 2021, our populations look pretty much the same. So again, for both of these time points, we're looking at a majority of healthcare providers that answered our survey who reported having at least some direct contact with patients. We have about a third in both groups, maybe a little less in the first round, that reported that they were healthcare providers but didn't have any direct contact with patients. And interestingly, we had this small sort of gray sliver that you see here of individuals who responded who were not healthcare providers. So the original plan and the email was set up so that we were recruiting healthcare providers, but we did get people outside of the healthcare provider profession who were also responding to the survey that was sent out. So they were working within healthcare provider settings, or organized healthcare settings or organizations such as hospitals or clinics, but they themselves were not necessarily healthcare providers. And so we had, for example, cafeteria workers and IT people from the computer departments that also filled out our survey. But again, this proportion was actually relatively small. In terms of the practice qualifications, again, we did notice some difference between 2020, the group that replied in 2020 versus 2021. So we had a more even split between nursing, public health, and clinical, which includes our physicians. The public health would include things like epidemiologists. But in 2021, most of our respondents were from the public health realm. In terms of the scores, in 2020, with if we're just specifically looking at the GAD-7, and we're taking the cut point as being at 10 or above, not surprisingly for us, the observed percentage of people, prevalence of anxiety in individuals was highest among those health providers with direct patient contact. And the prevalence was pretty evenly split in terms of between the no direct patient contact group and the non-health provider group. The split actually looks a little bit different when we're looking at the more current data for the second wave. And we noticed that in this case, the prevalence of anxiety is highest in the no direct patient contact group, healthcare providers with no direct patient contact group. And we're still exploring why this might be. It's a result that was a bit unexpected. We hypothesize maybe it could stem from sort of the mental health effects that are coming into play, maybe some of the administrators experiencing some of the fatigue, but again, we have yet to come up with sort of a good explanation for why we're seeing that particular result. The SDI scores for both 2020 and 2021 aren't incredibly different in the group. And so we didn't really notice any sort of statistically significant difference between the 2020 and the 2021 scores. There is quite a correlation between these two tools in terms of what they're measuring, which is anxiety. So the correlation between them is, I think, 70% or just slightly less than 70%. But maybe using the cutoff and the fact that they're maybe capturing slightly different aspects of anxiety could be why we're seeing some of these differences between the tools themselves and also between the groups. With the modeling, and again, I just want to emphasize that this modeling is just coming from the first wave, because we're in the process of analyzing the data from the second wave. We did find some predictors that were associated with an increased risk of state trait anxiety in the group, which included being a registered nurse. So as you can see, being a registered nurse was associated with an increased risk of state trait anxiety. We did notice sort of protective effects or effects that went in the other direction, if you will. These included increasing age and also working in primary care, neighborhood, community health clinics, and other sort of health service agencies. So with regards to age, we hypothesize that this is probably related to experience. So individuals who were older and had more experience working in hospital settings, maybe had been through the SARS pandemic, had lower state trait anxiety than younger individuals or younger workers. In terms of the type of healthcare organization, again, we theorize that perhaps it was the tertiary care hospitals that were seeing more of the complex cases. Maybe they were seeing more of the COVID cases in general, which could explain why everything else in comparison was looked like it was a protective effect. We got slightly different results when it came to looking at generalized anxiety disorder using, again, the cut point. So we're looking at these logistic regression in this case. We found the same trend with regards to age. So an odds ratio that was lower among among those that were older. We did note that the healthcare that the odds of generalized anxiety disorder was actually lower among non-healthcare providers. Again, it's not a complete surprise in this case. We did get slightly different results when it came to looking at the type of organization that the individuals reported. So we had, instead of the tertiary care hospital results that we saw with respect to the STAI scores, what we noted here was that secondary care hospitals tended to have an increased odds of generalized anxiety disorder. And again, this is something that we're still exploring, and yeah, we're not quite sure why we're seeing these particular results. We did also note that in terms of administration positions held, whether or not individuals had an administrative position, what type of administrative position that they did hold, that this was also associated with an increased odds of the GAD. And in particular, if we look at the assistant vice director of hospital center, which is here, that there was an increase, a significantly increased odds of developing the generalized anxiety disorder according to our cut point of 10 or above on the scale. And again, and maybe this is this is reflective of, we hypothesize this could be reflective of directors or owner managers having to look at after large teams of people, manage people who are testing positive for COVID-19, filling gaps in personnel rosters, and just sort of managing the whole the day-to-day logistics of running a unit during a pandemic. So in terms of the interviews, we were actually able to interview about 20 healthcare providers from this group between May of 2020 and December of May and December of 2020, pardon me. And you can see sort of the breakdown in terms of the demographic characteristics of the individuals that we did interview. So most of them were women. Most of them fell between the ages of 30 and 49. And again, this is something that is sort of reflected also in some of the results that we're seeing in our modeling, is the proportion of individuals who have at least 10 years or more in terms of experience in this field was higher than those with less than 10 years. And overwhelmingly, respondents that we interviewed were focused in the clinical medicine field. So these are some of the results to start emerging from our data with regards to the healthcare provider interviews. And so some of the themes that we're noticing that we're pulling out of the qualitative interview or the qualitative data include things like such as the hospital pandemic response, concern about patient and caregiver well-being, this strive to maintain work-life balance, and again, this concern and this and really this desire to have a sort of psychosocial support and focus on the psychosocial sphere. So this was related to both the healthcare providers themselves and healthcare services. But there were also larger themes that started to emerge from these conversations, including the protection and prevention, like the government response basically in terms of protection and prevention, what was being communicated to the general public, and how news and information was being shared and where this is coming from. We also tapped into some experiences of the healthcare providers who had heard of and had some familiarity with the internet-based cognitive behavior therapy intervention, the Moms Give Mood. And so we did ask some individuals about that. And we also assessed this group in terms of what are your views towards mental health as well. So that's something that we're also, evaluating at this stage from these interviews. So in conclusion, not surprisingly, COVID-19 has had an impact in terms of the mental health and mental well-being of pregnant and postpartum women, as well as healthcare providers. It appears, although this is still in the early stages, that changes, we can see changes over time, especially when we're looking at the healthcare provider data. Our early preliminary data from pre-COVID is suggesting that the internet-based cognitive behavior therapy program, the Moms Get Mood, is actually improving EPBS scores in women. So it's lowering their risk of depression. And the other conclusion I think that we can draw so far from this data and from this study is that there really is this lack of longitudinal studies when it comes to looking at this issue in both groups. And so we were lucky enough to be well placed to be able to take advantage of the longitudinal data for the women. But with the healthcare providers, again, we were just pivoting on the spot like many other groups. And so we were only able to capture data during the pandemic and hopefully a little bit after. So again, that is a limitation of our study as well. Just before I wrap this up, I just want to I flashed this slide up the last time when I was talking about our project getting started last year. But again, just to remind, just as a sort of a reminder and to share with you what we hope to accomplish with this and our research goals with this particular project. And it really is, we started with this and we pivoted to focus on the COVID-19 because we were hoping to be able to generate information that would help mitigate potential psychosocial stress and issues, and to help inform clinical and public health responses as we move forward through the pandemic. Another big goal of ours was, again, to assess and sort of confront this idea of mental health, the mental health stigma that's still attached to mental health issues in China, and really to highlight the importance of psychosocial support during emergencies such as this, and the need to include this as part of health service provision packages. So one of the things that we did note that when we applied for funding from the CIHR, that the primary focus in the early days of the pandemic was very much focused on the biological clinical aspects of the disease, which is, an important critical aspect. But our work sort of was a bit off to the side because we were looking at the mental health aspects, which not a lot of other groups had focused on at that time. I think definitely this has changed and we have more research that is coming into the space, which is great. So yeah, just to sort of keep in mind that this mental health, and as a reminder for when we're talking about responses to pandemics, that the mental health aspect is also a critical component of this as well. So my last slide is just, again, an acknowledgement of the team and the healthcare providers and the participants who so generously donated their time during this period of time when it was very busy and hectic. I'd like to thank our funders, who include the Canadian Institutes of Health Research and National Natural Sciences Foundation of China, and Alberta Innovates, who also co-funded the COVID-19 project. So with that, I'd like to thank you for listening, and looking forward to any questions or discussions that may arise. Thank you.